last 2 points and we end the long class is about hernias. Now, a couple of days back, when I was teaching about a group of students, my postgraduates, about hernia, it became very difficult for me to make them understand about this one. And hence, I took the CT scan of the abdomen. Yesterday in the emergency, we learnt about this to be the colon or the right side of the colon. This is the mesentery of the intestine. But now my attention is not on this one. Hello, guys. Am I audible, guys? Hello?
Yes, sir.
Hello? Right.
Yes, sir.
So, whenever you think about a hernia, whether we should do a CT scan, we are coming to when should you do a CT. Understand the CT concept, that is very easy. This is the umbilicus, always remember. And the umbilicus, please see the peritoneal continuity. If there is an umbilical hernia, obviously, this is going to be like this. Very simple bottom line things. Point number 2. Now see the muscles. The third muscle down here, which I should use 3 colors. This muscle down here is the transversus abdominis.
Yes.
The second muscle, which appears much more bulkier, okay,
An oblique.
is the internal oblique. I think you can see the bulkiness of the muscle, how bulky that muscle is. Okay. The last of the muscles is this one, which is the external oblique. Okay, which is the external oblique now. And if you can now find these 3 layers of muscles, what is very important is that see that the external oblique makes an aponeurosis and then thereafter goes to make the anterior rectus sheath very prominently. The posterior rectus sheath at the level of umbilicus is still evident. I am not very clear about this area, what is that one, but what I am obviously very clear of is that I can get to see a muscle, okay, which is the rectus abdominis. And if this is the rectus abdominis muscle, the rectus abdominis on both the sides look oval, which for me is a good healthy rectus abdominis. So a healthy muscle will be gray in color. And how do I know that this is a normal muscle? Very simple. All patients will have the same colors. If you compare this color and if you compare this color, remember that the color should be the same. That means their attenuation on a CT is the same. That means it is a healthy muscle. If it is a healthy muscle, now if you think over a hernia then is understood just exactly by understanding these layers. And now consider this one. So guys, what is your diagnosis from this one?
Umbilical hernia.
Ventral hernia.
Very good. You can see very quickly now an umbilical hernia. The mushroom is very evident. What is the content in this hernia?
Mesentery.
Very good. The content is
Momentum.
okay. How could you say it is omentum, not a bowel wall?
Very rare.
No, guys.
Contrast is not visible.
Number 1, sir. Very good point said. This is the loop of the bowel. You do not get to see a loop of the bowel outside. When we'll be talking ventral hernias, we'll be seeing into that. What is important is I can see something which looks like the color like this is more darker. If this is the mesentery M, this is more darker than the mesentery. So what can this thing be? What can that thing be?
Momentum.
Fat.
Okay. Is it
That's
viable or is it not viable? What is your opinion?
Viable.
Is it a viable? Is it a viable opinion, or is it a viable momentum, or is it not a viable momentum?
Viable.
Okay. Why did you say
Not
it is viable,
viable.
sir? Why did you say it is viable, sir?
Due to the enhancement.
This is the point, guys. I would like to see the arterial phase. Now, this is not exactly the arterial phase. The aorta is not very well seen. In the arterial phase, if I consider that this is the arterial phase of the disease, and omental vessels, if they are seen, should be making me think over that if I can see in the arterial phase, okay, and this is the vena cava, if it takes up the good color in the arterial phase, then maybe this is there. But in this one, I'm not very sure about the vascularity, but maybe a white dot in this area suggests that yes, this probably is a viable piece of momentum, but this is an irreducible one because the neck of the hernia is like this. What is the status of the rectus abdominis muscles? Okay or not okay? What is the status of the rectus abdominis?
Okay, sir.
Okay.
Okay, more or less grossly said, they appear to be okay. I do not know what is this pathology. Okay, but more or less, sir, I'm not very unhappy with the rectus. I'm happy. Okay, so now see this one. If that was an umbilical hernia, this is another hernia. What is this one? Okay, so this is an hernia that has occurred on the flank. Now, definitely this is the lateral abdominal hernia, probably a spigelian. The differential diagnosis, if I get more cuts, will be an inferior lumbar hernia. But one thing is very sure, you can see the gap between the iliac crest and the parietal muscles. If these are the three muscles, this is a much lower cut, and in this cut you can see the hernia. What is the content in this hernia? Is a bowel loop, and you can see this bowel loop very clearly. Very good. Now, talking about ventral hernias, the reason that we should do a CT. Ventral hernia number 1. Midline hernia, what is the content of the hernia?
Bowel. Bowel.
Is bowel loop. Now, points to observe in this part. The first and the most important point to observe in this part, ladies and gentlemen, is only one. Number 1 is that see the three muscles: external oblique, internal oblique, transversus abdominis, rectus abdominis, rectus abdominis, external, internal, transversus abdominis. So that means basically this is a midline hernia. The midline hernia, as you can see, has a wide neck. What I am more interested is in seeing what is the distance of separation of the two medial margin of the rectus. If the gap is more than 10 centimeters by the CT scan measurement, this is going to be a tough thing for you to close. Point number 2, the content in the hernia is gut, which, believe me, is very subcutaneous. That means probably the patient had a history of laparotomy, abdominal wound dehiscence, and the bowel is now stuck up with the parietes. Should make you very afraid when you are going in the abdominal cavity. Right. Now, in contrast to this picture, see this one. Now, see this one. In this picture, so this is, just a second. Now, where did it go? Okay. Now, see this one. So, this is the transversus abdominis, internal oblique, external oblique, external, internal, transversus, rectus abdominis muscles. Now, guys, can you see the status of the rectus abdominis in this? What is anything wrong with the rectus? Anything wrong with the rectus?
Not so healthy.
Very good. In contrast with this rectus, compare with the color of the fat of the back muscles like these ones. If this is a healthy muscle, compare the rectus abdominis muscles in contrast with the other muscles. Like this, if this is healthy, I do not get a bulk of muscle in this plane, so I need to compare with the psoas muscles. This rectus abdominis appears to have some black areas, which means that the perfusion is not okay. Even if you see the right rectus abdominis appears to be a bit atrophied in contrast with the left side. Plus, so that means what are the points that I look into? I look into the gap, I look into the status of the rectus abdominis muscles. That means that, remember, if the rectus abdominis is bad, the perforators which pass through the rectus abdominis are also bad. That means if you are placing a retrorectus sheath in this, if you are placing a retrorectus mesh in this area, This is not a very good area because the tissues are not in a very good shape. Plus, you can see the content in this. However, there is another side of the story. Another side of the story tells you that see the amount of the bowel that is in the peritoneal cavity with bowel that is outside the peritoneal cavity. If this volume is X and this volume is Y, X should be greater than Y. That means if you consider that this is the abdominal cavity with X and this is the abdominal cavity with Y, X should be greater than Y if it is a reducible hernia and you are expecting a good outcome is this. However, if it becomes the Y is greater than X, your smile should always go away. Because this is then what type of hernia? Called as a
Loss of domain.
loss of domain hernia. In this patient, what is wrong with what muscle?
Rectus.
Very good. Number one, not only the rectus, sir. See the status of the three muscles. If this is normal, this muscle appears atrophied. Now you understand how do we plan around the component separation. If they're doing an TAR, what is the way that they will do by? Again, see the amount of viscera that is in the bowel. Based on this, there are two indexes that is something that is goes beyond a postgraduate, and particularly if you are a hernia surgeon, either they use a Tanaka method or they use a Sabag's method. But it will require your radiologist to tell you what is the amount of area that you have. That means if this is Y and this is X, it will require you to tell from the radiologist what is the volume. That means if this is the volume Y, this is the volume X, what is the difference in the two volume? Remember that what is the difference between the two volume? So if you want to take a snapshot of this picture, what is the loss of domain? The loss of the domain is done by either a Tanaka ratio or a Tanaka method, or a Sabag's method is something that you should know. Okay, so loss of domain definitions are very doubtful definitions, debated definitions around what exactly is a loss of domain. But what is very more or the less is that if there is more than 20% of the volume, like say for example in this picture, if there is more than 20% of the loss that has occurred of the bowel into that, or that hernial sac volume is more than, that means if this is 80 and this is 20, then more than 20 will call it as a loss of domain hernias. And then some people will do a progressive pneumoperitoneum. Some people will do a progressive pneumoperitoneum for treatment of this part. Okay, so this goes on to complete this part again. Now, so this completes the last one and we end the class now. Any questions on hernia before we end?
Sir, what gas do we use for the pneumoperitoneum? Progressive
Carbon dioxide.
pneumoperitoneum.
Carbon dioxide, sir.